So one of the first thing that a cancer cell does is it acquires the ability to sustain proliferative signaling. So why do cells divide in the first place? So they divide in response to various signals. So they may respond to growth factors or some internal signals. So all these signals within our body have checks and balances. So when a cell gains autonomy over this, when it no longer depends on those regulated checks and balances, it will have established an autonomous lineage. That is, it will have sustained proliferative signaling. It can either derive its signals from within, or it can basically no longer be dependent on external signals. And something has to halt growth normally. So if it can evade the usual phenomena that halt growth, so it acquires sort of growth inhibition, so it can divide or grow uninhibited. So this is one very, very important hallmark of cancer. And it evades immune destruction. So there is usually something called immunosurveillance within the body, where the body's natural immune system surveys the blood and the various tissues for non-self antigens or cancer antigens, in addition to other things like microbes. And the cancer cells can develop a mechanism by which they evade immune destruction. So they are no longer susceptible to the destruction by the immune system. So this leads them to survive despite being, errant or mutant. One other property that cancer cells acquire is replicative immortality. And other properties such as invasion and metastasis, and inducing angiogenesis and evading cell death or apoptosis, and deregulating the energetics of the cell itself. So all these are various means by which cancer cells behave the way they do, and we will look at each of them one by one. So what exactly does it mean when you say that a cancer cell can sustain proliferative signaling? So cancer cells can acquire self-sufficiency in growth factors. So growth factors are those molecular chemicals which help in growth and division of a cell. So these are generally released by various tissues in response to various physiological stimuli. But these cancer cells can sometimes, acquire the ability to generate those growth factors on their own. So the growth factor that has been generated by a cell can act on the same cell and cause its growth, wherein it is called autocrine action, or it can act on the cells around it and cause them to grow or proliferate, and this is called paracrine action. So by this mechanism, some cancer cells can acquire self-sufficiency in growth factors. So that is not the only means by which proliferating signaling is sustained. One other thing is some intracellular proteins which respond to these growth factors are modified in such a way that they are hyper responsive to these growth signals. So usually if a growth factor binds to its receptor, it will cause downstream action causing growth or proliferation for a limited period or for a limited quantum. If these intracellular proteins are so modified, they can become hyper responsive to those growth signals, and the growth will perpetuate indefinitely, though the growth factor will have stimulated it just once. And this is something that we see in KRAS proto-oncogene activation, wherein there is a pathway called the MAP kinase pathway, which becomes so modified that when BRAF acts on it, it perpetuates cell proliferation indefinitely. So this is one mechanism by which cancer cells sustain their proliferative signaling. So generally, growth does not happen in normal cells. Growth does not happen, uninhibited, because there are some negative feedback mechanisms in place which will regulate the proliferative signaling. So if that is disrupted by the cancer cell, within the cancer cell will no longer respond to the checks and balances of negative feedback, and proliferation will go uninhibited. So by this mechanism, it sustains proliferative signaling. And there are certain growth suppressors in the cells that will, suppress their indefinite growth. And such suppressors are, molecules such as the tumor suppressor gene, such as the RB gene or the retinoblastoma gene, the TP53 gene, which is also known as the guardian of the genome. So, and one other is NF2, which is whose mutation is responsible for neurofibromatosis 2. So all these are tumor suppressor genes in the sense that they suppress, cell proliferation by acting on various stages, either on various stages of the cell cycle or other, aspects of cell proliferation, making sure that, mutant tumor cells with DNA damage do not replicate and do not become dominant within the organism. So if these tumor suppressor genes are suppressed, if the suppressor is suppressed, there can be evasion of, the checks and balances to growth. And this will lead the cancer cell to divide uninhibited and unchecked. One other natural pathway within the body is the TGF beta pathway, or the transforming growth factor pathway, which basically acts as an anti-proliferative pathway. So if that is disrupted, there can be evasion of growth suppression as well. One other thing that we were talking about is how cancer cells evade immune destruction. So they escape the natural phenomenon called immunological surveillance. So the immune cells that are responsible for immunological surveillance are cytotoxic T lymphocytes and natural killer cells. So they are all part of the human body's non-specific or first line of defense, and they are on the regular lookout for cancer cells. So they find cancer cells and are responsible for the destruction of those cancer cells. But how do cancer cells then escape these immunological constituents that will destroy cancer cells? They do so by either secreting TGF beta or other anti-proliferative factors, which will act on cytotoxic T lymphocytes and natural killer cells. And this will cause immunosuppression, and thereby these cancer cells escape the immunological surveillance that is naturally in place. Some cancer cells also express some immunosuppressive cell surface ligands. So on the surface of the cancer cells, you will find ligands such as the PDL1. So all these are potential, targets for immunotherapy in cancer, and we will come to that shortly. So one other property that is displayed by cancer cells is something called replicative immortality. So one thing that we should all understand is, normal cells, normal mammalian cells, they are not, they do not undergo infinite number of divisions. So the number of times that the cells can divide is limited, and this is something that is, that is proposed by the Hayflick hypothesis. And it is stated that, normal mammalian cell, most normal mammalian cells can only undergo 40 to 60 number of divisions throughout the life of that organism. So why is it that these cells cannot divide beyond, say, 40 times or 60 times? So what imposes this limitation is the progressive shortening of the end of the chromosome. So if you can remember your molecular biology and cell biology, you will remember that the terminal end of the chromosome is called a telomere. So each time a cell divides, the telomere gets progressively shorter. So every time the cell divides, a small length of the telomere is knocked off the chromosome. And this telomeric shortening is a sort of molecular clock that will determine the number of divisions that can happen in a single cell lineage. So if the telomere becomes so short that it disappears, the cell can no longer divide. So how do cancer cells circumvent this? Cancer cells have the ability to generate an enzyme called telomerase. So this telomerase causes the lengthening of the telomeres. It rebuilds the telomere at the end of each cell division. So each time the cell divides, not only does it replicate its entire genetic material, the telomeres at the end of the chromosome also gains length. So by this, it is perpetually immortal because the telomeres never go short. The cell lineages never get snuffed out. They perpetuate for ever and ever. And that is why cancer cell lineages do not die out like normal cell lineages do. And by this, the cancer cells attain replicative immortality. One other, cardinal feature of cancer cells is their ability to invade and their ability to metastasize. So what is invasion? So cancer cells, they cause a breach in the basement membrane. So they are epithelial cancers, it has a basement membrane, which it can invade. So how do cancer cells invade the basement membrane? By their sheer number. Okay, so they exert a pressure effect. They increase the interstitial pressure within the tissue, and that can cause breaches in the basement membrane. Cancer cells also develop the ability to secrete a couple of enzymes that can dissolve the extracellular matrix. So cancer cells can synthesize proteases and collagenases, which break down the proteins of the extracellular matrix and allow them to invade through the extracellular matrix. Cancer cells can also modify some cell surface molecules such as integrins. So if you can remember your cell biology, integrins are cell surface molecules that help in cell-to-cell adhesion and the adhesion of the cell to the surrounding, basement membrane or the surrounding ground substance. So if these cell surface molecules are modified in cancer cells, the cells can detach and therefore attain some sort of mobility. They can move and spread. So this is, on the spectrum of invasion to metastasis. So once the cell, invades through the basement membrane, it can then intravasate into the lymphatics or the blood vessels. It can actually enter, it can permeate through the cells which line the lymphatic vessels and the blood vessels, thereby gaining access into the lymphatic system and the general systemic circulation. So what happens when the cancer cells enter the lymphatics? They move through the lymph channels to various parts of the body. Usually, they first move to the regional lymph nodes. So this is called nodal metastasis. And when they gain entry into the vascular system or the blood vessels, they undergo transit throughout the blood vessels, and finally they extravasate into the parenchyma. So the blood vessels which lead to various parenchyma such as the liver, the lungs, once the cancer cells reach there, they extravasate into the parenchyma. And there they form small nests of tumor cells, and this is called micrometastasis. And once they colonize these organs, they again proliferate and divide and form, sizable, substantial metastasis. And this is how distant metastasis occurs. So you must understand that this is not simply because of the properties of the tumor cells, but also because of how the mesenchyme, responds to and interacts with these cells. So this epithelial mesenchymal transformation that happens during the natural history of cancer is very, very key in invasion and metastasis of cancer cells. So one other property that cancer cells acquire is their ability to induce angiogenesis, or the ability to induce the formation of new blood vessels or tumor neurovasculature. So this is something that results by the activation of something called the angiogenic switch. So there are a lot of pro-angiogenic signals that are generated by the activation of oncogenes such as RAS and MYC, and all of these stimulate the production and action of VEGF-A, or vasculoendothelial growth factor A, which is responsible for the formation of new blood vessels or neovasculogenesis. So this is normally inhibited by thrombospondin 1, and thrombospondin is generally suppressed in most cancers, especially in solid tumors. So because of all this, tumor neovasculature develops, and it derives contributions from pericytes and some bone marrow derived cells such as vascular progenitor cells, macrophages, mast cells, and myeloid progenitors. And because of this, the tumor develops its own very own blood supply, and these blood vessels are not normal blood vessels. So how are they different from the usual blood vessels that we see? tumor blood vessels are, they show precocious capillary sprouting. That is, even before the blood vessels reaches its terminal end, it sprouts capillaries. That is, it is highly branched, and it shows a lot of convoluted and excessive branching, and the vessels are distorted and enlarged and often leaky. So that is something that leads to the classical clinical feature of most solid tumors, which is their a tendency to bleed on touch. That is because of these abnormal and highly unstable neovasculature or new blood vessels. One key aspect of cancer cells is their property of evading apoptosis or programmed cell death. So there are so many, intrinsic and extrinsic pathways within a cell. If you happen to remember your, cell death area from pathology. So all those, natural pathways that lead to programmed cell death are circumvented by cancer cells. So it can be either because of, the loss of TP53 function. Like we were talking, where TP53 is the guardian of the genome, and it causes cell death of those cells in which there is DNA damage. And tumor cells can also evade apoptosis by the expression of a lot of anti-apoptotic regulators such as BCL2 and BCLXL. And it can also be due to increased expression of survival signals such as IGF, that is insulin-like growth factor 1 and 2. And a lot of BCL2 related factors such as BAX, BIM, and PUMA are downregulated in cancer cells. And cancer cells also short circuit the extrinsic death ligand or the fast ligand pathway. And one way that cancer cells, ensure their ability to grow, survive, and proliferate, and maintain themselves over a long-term period is by rewiring the metabolism of the cell itself. They modify the cellular energetics in order to optimize for maximum growth, survival, and proliferation at the cost of cellular function. So how do they do this? So one very, very extensively studied, a change in cellular energetics is the Warburg effect. And this was described by Otto Warburg in 1920. So this is a very, very interesting phenomenon where, cancer cells have a very high glucose uptake. So what generally happens in mammalian cells? We are all, mammalian cells, and they generate ATP by aerobic respiration. That is, they take up glucose, they break it down to pyruvate, and pyruvate, goes through the, aerobic respiration through the Krebs cycle to finally, generate a lot of ATP. So this is what generally happens in normal cells, and though this is a time-consuming process, it is very energy efficient. That is, it generates more ATP per unit of glucose burned down. But this ATP production is not fast enough for a cancer cell for its metabolic need to lactate. And this happens despite there being aerobic conditions, despite there being enough oxygen to, for the cellular substrates such as glucose to be completely broken down to carbon dioxide and water. Despite this, it undergoes lactic acid fermentation. And though this generates very little ATP, it generates the ATP 10 to 100 times faster. So this is one, change in cellular energetics whereby cancer cells, adapt to, grow faster and survive by very, very quickly breaking down glucose to generate energy, that is ATP. And cancer cells also display an improved tolerance to relative hypoxia. So even in conditions where the oxygen supply is low, they manage to survive. They manage to tolerate relative hypoxia, and this is especially seen in the center of a tumor. The center of a tumor is usually the area of the tumor where the blood supply is the poorest, and thereby the oxygen supply is the least. even there, the cancer cells can survive because of their improved tolerance to relative hypoxia. Okay, so now that we've understood the various hallmark features of a cancer cell, we must now try to understand the dynamics of the growth of a tumor. So we can, it is very, very easy for us to assume that, tumor cells, display exponential growth, where, the number of cells that result from, each, consecutive division cycle is 2 to the power n, where n is the the number of divisions that the cell lineage has undergone so far. But it is not that simple, because if that were the case, if exponential happened throughout the life cycle of a tumor, we would soon have very, very, very large tumors that would cause instant death. That is not something that we see in most human cancers, isn't it? So the tumors also have a phase of sustained and gradual growth before they become apparent. So why is this? This is because of a phenomenon exhibited by most tumors called the Gompertzian growth pattern. So most cancer cells will initially have an exponential growth, where the number of tumor cells undergoing divisions in unit time increase in accordance with the order of 2 to the power of n. But once they cross the limit of clinical detection, that is, it is generally said that for solid tumors they become palpable. I mean, they're at least 1 centimeter in size, and it differs for various tumors based on their location and the size. Once they cross the limit or threshold of clinical detection, we see a perceptible decrease in the growth rate of the cancer or the tumor size, and this happens because of cell loss. So the cell loss can happen because of nutrition issues, where the cells compete with each other for nutrition and for oxygenation. That is, they do not, the rate of the tumor growth will outdo the availability of blood supply and oxygen. So because of this, there is a lot of cells which are constantly dying within the tumor population, and this cell loss is what causes a decreased growth rate. And this relative decrease in growth rate in the later part of the tumor's life cycle is called Gompertzian growth. So with all this in mind, let us now go to the epidemiology of cancer. So what causes cancer? Is it bad luck? Is it bad environment, or both? One thing that we have to understand is cancer is now understood to be a multifactorial disease with various responsible causative or contributory factors. Sometimes it can be sheer bad luck, where cancer results from inherited syndromes, which are either autosomally dominant with autosomally dominant inheritance patterns, or recessive or X-linked inheritance patterns. So these are passed on from generation to generation with relatively high penetrance and variable expressivity, and they manifest as cancer. So a couple of cancer syndromes that are widely studied and understood are FAP, or familial adenomatous polyposis, or Gardner syndrome, which happens due to a mutation in the APC gene. Then hereditary non-polyposis colon cancer with mutations in MSH2, MLH1, and TMS1. And the Cowden syndrome, which happens due to mutation in the P10 gene, retinoblastoma, and then the multiple endocrine neoplasia syndromes 1, 2A, and 2B. So all of these are inherited cancer syndromes, and this is not an exhaustive list. This is just an overview of the most well-known cancer syndromes. And sometimes it is not just the mutation, that leads to the cancer. So we have one very interesting hypothesis called Knutson's two-hit hypothesis, where the first hit is a genetic phenomenon or an inherited phenomenon, where one copy of the defective allele is inherited from the parent. But then there is almost always a second hit which will push the organism to develop cancer, and that is usually environmental. Okay, so it is a it is when the second copy is destroyed, the second copy of the allele also becomes defective. It is then that the cancer manifests. So that the second hit is usually due to various adverse environmental factors such as exposure to tobacco, alcohol, UV rays, and having a sedentary lifestyle with obesity and being exposed to ionizing radiation. And one other very important, carcinogen is viral infection. So viral carcinogenesis is increasingly being studied today. And we all know that the human papilloma virus is implicated in cervical cancers, and HIV results in, typical cancers such as Kaposi sarcoma. And, there are so many AIDS defining malignancies which happen as a result of infection with the human immunodeficiency virus. And we know that the hepatitis B virus is implicated in hepatocellular carcinoma, as is the hepatitis C virus. And we know that the bacterium Helicobacter pylori, which is responsible for, gastritis and various other gastric conditions, is implicated in adenocarcinoma of the stomach and some gastric lymphomas as well. And parasites such as schistosoma are implicated in bladder cancer, and various parasites of the biliary tree such as Clonorchis and Opistorchis are implicated in cholangiocarcinomas or bile duct cancers. Also, fungi such as aflatoxins are responsible for liver malignancies, and chemicals such as vinyl fluoride are implicated in the angiosarcoma of the liver, aniline dye in bladder cancers, and so many, ironically, so many anti-cancer drugs and immunosuppressives are implicated in cancer too. So the causes for cancer are diverse, multiple, and complicated. That is one thing that we have to understand. And this understanding is exceedingly important because it helps in at least preventing a modicum of these cancers. So how can we prevent cancers? So one of the very simple and also reasonably effective methods of preventing cancer is health education. That is, you educate the general public regarding the various risk factors for cancer and what they can do to prevent. So if it is if the index patient or a particular person is exposed to environmental carcinogens, known environmental carcinogens such as tobacco, alcohol, or some industrial chemical, we can actually educate them to prevent exposure to those known carcinogens. And in patients with a genetic history of inherited cancer syndromes, genetic counseling can be offered, and often chemoprophylaxis and prophylactic surgery can be done in select cases to prevent progression to full-blown cancer. One very, very popular example is in carriers of the BRCA1 mutation, a prophylactic bilateral mastectomy with, a total oophorectomy can be done in a bid to, prevent breast cancer and ovarian cancer, whose likelihood is close to 80 to 90%. So carriers of that mutation are almost always, likely to develop breast and ovarian cancer. So in such cases, prophylactic surgery may be indicated. Prophylactic total thyroidectomy and carriers of the, RET oncogene, which is seen in MEN2 syndrome, is another education for prophylactic surgery. We also advocate screening in the management of cancer. So screening is the is when you subject apparently normal individuals without any symptoms to various investigative modalities to see if they have cancer. So one of the most common examples for cancer screening programs is deploying mammography as a screening tool in women who are older than 45. So we often advocate mammograms coupled with self-breast examination and clinical breast examination. Also, pap smears are done in order to detect cervical cancer and the precursor lesions such as intraepithelial lesions such as intraepithelial neoplasias. And colonoscopy is done in select patients with family history of colorectal cancers to to aid early detection and thereby manage the condition better. And once the disease has set in, we have various modalities of diagnosis and staging. And then comes the actual treatment of cancer. And the treatment of cancer is now carried out by multidisciplinary teams with personnel who are skilled in surgery, radiotherapy, chemotherapy, and biological therapy. And treatment can either be curative or palliative. And treatment also includes long-term follow-up and rehabilitation of the patients. So let us look at all of this one by one, and let us now look at cancer screening. Like we just said, screening is when you subject apparently asymptomatic or normal individuals to various investigative modalities to see if they have the disease. And in this case, it is cancer. So what are some considerations in cancer screening? So we have something called lead time bias. This is a very interesting phenomenon. And this is something that happens when, you detect the tumor by some screening modality. So, let us study this. Say that, if the, okay, let's make this simpler. So say that you are screening a patient for a tumor, and let us assume that this tumor is something that has a relatively steady and gradual progression. So let us now understand how exactly lead time bias works. So at some point in the progression of the tumor, let us say that it becomes detectable by screening at this point. So this is the threshold for, this line is the threshold for when the tumor becomes detectable by that particular screening. Okay, let us now take the example for breast cancer. Let us say that if we plot the time in months along the x-axis and the tumor size along the y-axis, let us say that at a point of time A, the tumor will become detectable by screening. So if you happen to do screening at this point in time A or sometime later, the chances of detecting, the cancer by mammography is possible. And let us say that B is the point where, the cancer acquires a size at which it is clinically detectable either by the patient or by the clinician. So this is when most cancers which are not screened for are generally picked up. So that is when the tumor size crosses the point B. Okay. And let us assume that C is the point of time in the natural history of the tumor where the cancer becomes fatal, or the point of time where the cancer kills the patient or the patient dies. So these are three very, very critical points in the natural history of this cancer. Say that, you are screening a particular person for, say, breast cancer, and you happen to do the screening when the tumor is at this point in its natural history. Okay, so this is when you have done the screening. This is the point of screening. So if you screen at this point and you detect the cancer, you have detected the cancer at this point. So assume that this is, say, A dash. You have, or let us say X, according to this. Okay, so you have detected the cancer at a time of XY, and this time XY is much earlier than what would, when the cancer would have been detected had you just let it to develop to a point where it crosses the threshold of clinical detectability. So now what is happening? You are gaining some lead time, or you are basically detecting the cancer earlier than the point of clinical detection. And if you look at the time of survival and count it as the time counted from the time of detection, that is from X to the point where the patient finally succumbs to the disease, or the point C. So this is the overall survival. It seems to be longer than this particular time, that is the time from, if you count it from Y. Okay, so if you take this point in time as Z, it is very obvious that YZ is much shorter than XZ. So we are assuming that by detecting it early, we are gaining a survival advantage of XY. But that is not really the case. You have merely diagnosed the cancer earlier, and the diagnosis needn't have actually, changed the natural history of the cancer. You simply, have started measuring the survival from an earlier point, and this bias is called lead time bias. So this is something that happens in cancer screening. One other bias that we may encounter in cancer screening is something called length bias. So this is actually a more it is more influenced by the biological behavior of the cancer and not merely by the screening method. Okay, say that you're now dealing with a rapidly growing or a more aggressive cancer, and we happen to screen for it way before it becomes detectable by clinical screening. So if we happen to screen for it very early, we haven't caught it, and say we screen for it again at some point, at which it has crossed the stage of clinical detectability and is close to becoming fatal. So between these two screening points, it has grown considerably, and it will there is a very, very, very short period before which the patient succumbs. So this is called a length bias. Okay, so this is something that is more a function of the biological behavior of the cancer, and you can infer that slower and less aggressive cancers are more likely to be detected by screening, and rapidly growing and aggressive cancers are more likely to be detected by symptoms rather than the screening. Okay, so this is another bias that we see called the length bias. And overdiagnosis is also a byproduct of aggressive screening programs and campaigns, where you happen to just detect a minuscule tumor that will probably not harm the patient. So the patient is likely to die with the cancer rather than die of the cancer. So this leads to a lot of unnecessary investigation and intervention. And a few other pitfalls of screening are stage shift, where you simply happen to diagnose a cancer in an earlier stage by screening, and the overall detection of the cancer at an earlier stage will give you an impression that there is an overall improvement in survival. This is again like an extreme form of lead time bias, where you see an increase in the overall survival, and this is merely because of early diagnosis and not because of actual intervention which is reducing the mortality. And then selection bias is one other thing that can happen, and guilty volunteer effect is again where screening studies tend to enroll individuals who are generally healthier than the general population, and this will heavily influence the results and distort them. So all of these apparent pitfalls or biases will impact conclusions about the mortality benefits in screening. Okay, so now that we have spoken about screening, let us briefly talk about diagnosis and staging of cancer. So the diagnosis and staging of cancer begins right at the point where you do a clinical examination of the patient. You actually elicit a history and do a physical examination. So this will right from the point where you elicit details regarding the onset of symptoms, the progression and the duration, and when you examine the tumor for the size, the extent, the appearance, the consistency, the mobility or fixity of the tumor, the lymph node status of the regional lymph node basin, and the evidence of metastasis, you are basically beginning the process of diagnosing and staging cancer. And cancer is one disease where diagnosis and staging go hand in hand. So this will aid, and it will set the stage for management and prognostication. And as we all know, in breast cancer, we have this triple assessment, and this can be extrapolated to most cancer. And triple assessment always begins with history and physical examination, followed by non-invasive methods of assessment such as imaging, and then invasive methods such as histopathological examination of some sort. So imaging modalities in cancer can be something as simple as the humble X-ray, or the ultrasonography, or CT scans, MRIs, and nuclear imaging modalities such as the PET scan, and various scintigraphy scans such as the bone scan, thyroid scintigraphy. All of these are various imaging techniques that are used in cancer. And then diagnosis and staging is also very, very, very dependent on histopathological examination. So it can be something as simple as an FNAC or a fine needle aspiration cytology, or something more substantial such as the core needle biopsy, where a small chunk of tissue is taken instead of individual cells, or incision biopsies where a part of the tumor is cut out and then examined, or excision biopsy where the entire tumor, usually along with the margin, is surgically removed and then subjected to examination. And the pathological examination of aids in the classification of the disease. Say, for example, you're dealing with lymphoma. Say you're dealing with Hodgkin's lymphoma. It's only by pathological examination that whether it is the nodular sclerosing type, or the lymphocyte rich type, or lymphocyte predominant type. All of those are very, very important in the management of the disease. So it helps you classify the disease. And modalities such as immunohistochemistry will help you further classify and categorize the disease so that you can intervene in a targeted fashion. Pathological examination also helps us in grading the tumor in terms of the degree of differentiation, whether it is a poorly differentiated or an undifferentiated tumor, or moderately well differentiated or well differentiated. So this will help in gauging the biological behavior or the aggressiveness of the cancer cells within the tumor. It also helps in pathological staging, especially in the local T staging is the gold standard for determining the stage of the cancer. Some more investigations such as blood investigations, that is assays for tumor markers, either specific tumor markers or non-specific tumor markers, and cell-free tumor DNA based tests that help in catching the specific mutation of the tumor cells are again important blood investigations which act as adjuncts to the other three. And there are so many molecular methods which have refined our understanding of cancer and are helping us to move towards a more personalized approach for treating cancer. And this can be by way of detecting mutations through PCR or restricted enzyme digestion, or cytogenetic studies through chromosomal analysis, or FISH, that is fluorescence in situ hybridization, and genomic tests such as whole genome sequencing and next generation sequencing, and the profiling of gene expression. That is, what is responsible for gene expression is the mRNA. So we do microarrays for various types of mRNA, and Oncotype DX is one such gene expression profiling that helps us to determine the need for chemotherapy in breast cancers. Okay, so once we have diagnosed and staged the cancer, we move on to its treatment. And like I told you, the treatment of cancer is multidisciplinary, and a very, very important tool in the armamentarium against cancer is cancer surgery. So, especially in solid tumors, a chance to cut is a chance to cure. So it almost always, bestows the possibility of a cure. So there are various roles of surgery in a patient with cancer. The surgery might be done for diagnosing and staging the cancer, as in the case of diagnostic laparoscopy. Say that you have a patient with a suspected gastrointestinal malignancy. So you do a diagnostic laparoscopy to either take small biopsies of the specimen from the target site, or to examine the viscera for signs of metastasis, or you probably will do a laparoscopic USG to understand the degree of invasion better, or take the setting of say a patient with a testicular tumor. The initial diagnosis and staging is done after doing a radical orchiectomy and then subjecting the testicular swelling to histopathological examination. And sentinel lymph node biopsies are another example of surgery being used for diagnosis and staging. So it is done in breast cancer, melanoma, and penile cancer to see if the sentinel lymph node is actually involved by the cancer, and whether a full-fledged lymph node dissection is warranted. Also, staging laparotomy is done before finalizing on the treatment plan in various cancers. So, beyond its role as a diagnostic and staging tool, its most important role is in the removal of the primary disease. So, like we were saying, a chance to cut is a chance to cure. So, depending on how complete your resection of the primary disease is, you can, say that it is an R0 resection or an R0 resection, where you have surgically eliminated even microscopic evidence of tumor cells, or an R1 resection where there may be microscopic evidence of residual cancer. And at this juncture, there is one surgical concept that we have to discuss. That is the concept of operability versus resectability. So when do you say that a cancer is operable? When do you say that it is resectable? So operability is when, your surgical procedure renders the patient completely tumor free. And this is mostly done in patients with, locally limited cancers, or in some rare cases, oligometastatic disease. So by the act of surgery, you are cutting out the entire cancer. If that is feasible, surgically feasible, it is called operable. Resectable is when you can cut out the tumor, but you can not eliminate the disease. And this is generally because, the cancer has spread to a distant site, and, completely surgically removing the tumor is no longer feasible, or because, the tumor is so locally advanced that, a complete elimination of the tumor by surgery is no longer possible. So these are the two scenarios which we generally encounter in oncosurgery. And like I was telling you, it is also possible to surgically remove metastatic disease. And this is generally done in colorectal cancer with, isolated lung or liver metastasis. And this has been enabled by our improved understanding of the segmental anatomy of these organs. So metastasectomy is a possibility in certain cancers such as colorectal cancer. And sometimes the only benefit that surgery can afford in cancer is just palliation. So say that a patient with advanced unresectable or metastatic cecal cancer comes to you with obstruction. So surgery may be employed to relieve that obstruction, and by constructing an iliotransverse anastomosis to bypass the obstruction due to cecal cancer. One other example of palliation is where, you do a triple bypass for unresectable cancer of the head of the pancreas. And another very, very important tool that is generally, deployed for loco-regional cancer control is radiotherapy. So this is, a modality which utilizes ionizing radiation or particles to, achieve loco-regional control of the tumor. So we use a lot of, different types of radiation clinically. And the radiation may be, electromagnetic waves in the form of photons, say X-rays or gamma rays. So X-rays are generally, they are generated or produced by linear accelerators. And gamma rays are emitted by some radioactive isotopes, such as cobalt. So cobalt is one of the oldest sorts of, radiotherapy beams that have been used in the treatment of cancer. We also use, charged particles such as electrons. So beta rays are nothing but a stream of electrons, and they dissipate their energy as they enter the tissue, and they are again a source of energy to kill cancer cells. So other particles that are used for cancer radiotherapy are protons, neutrons, and some heavy ions such as carbon anions. So how exactly does radiotherapy kill cancer? So it can either be indirectly, that is by the generation of hydroxyl radicals from water. So, tumors have water content, right? They have moisture. So from that water, because of the action of these radiations, there can be a generation of hydroxyl free radicals. So these free radicals will in turn act on chemical bonds within the DNA and cause DNA damage. So as you all know, DNA damage is lethal to the cell. So the more direct action of radiation is where the waves or the electromagnetic radiation will directly act on the chemical bonds within the DNA and cause various sorts of DNA damage, such as base pair damage, cross-linking damage, and breaks in either the single strand of DNA or the double strand of DNA. All of this is lethal to the cell because this prevents mitosis. So when there is DNA damage, mitosis cannot go forward, and this mitotic death causes loss of reproductive integrity. And sometimes, cells with DNA damage can also undergo apoptosis. So by these mechanisms, these radiations can cause tumor damage. So there are some words that you will likely encounter while talking about radiotherapy. And one very, very important word is fractionation. So once you determine how much of, what dose of radiation has to be given to a cancer patient, you can give that total dose in various ways. So fractionation is when you break up the total dose into smaller fractions that are given repeatedly. And this is a strategy that is employed in order to balance tumor control and also the damage that is done by the radiation to the normal surrounding tissue. So one very common buzzword here is the 4 R's that are associated with fractionation radiobiology, and those are reoxygenation, repopulation, repair, and redistribution. So as you just saw, we looked at the indirect methods by which radiation damages cancer cells, and that is by generation of hydroxyl radicals. So for the hydroxyl radicals to be generated, oxygen molecules have to be available in the close proximity. So as you know, once the tumor cells become oxygen depleted, this indirect action of radiation is no longer possible. So by fractionating the dose, that is by allowing some period between 2 doses of radiation, you allow time for enough oxygen to diffuse into the hypoxic center of a tumor cell, and this enables better tumor killing. That is why fractionation is an effective strategy. One other thing is repopulation. So by fractionation, you are allowing repopulation of the tumor tissue. So once there are a lot of cells that are dividing by mitosis, the number of cells that can be targeted by the radiation increases, and this helps in better tumoricidal effect by the radiation. So repair is one other R that is achieved by fractionation. So by allowing basic time to elapse between 2 radiotherapy sittings, the radiation damage that happens to the normal cells can be repaired by the cellular machinery. So this helps in better compliance and better well-being of the patient. So one last R that we see with fractionation is redistribution. So as you know, there are various phases of the cell cycle, and the sensitivity of the cells to damage by radiation is highest at the G2M junction, and the cells are most radio resistant during the S phase of the cell cycle. So by fractionation, what happens is the time period that is given between the 2 doses will allow more cells to enter relatively more radiosensitive phases, such as the G2M junction, and this allows better targeting. So these are some principles of radiotherapy that you should understand, and there are more fractionation schemes such as hyperfractionation, accelerated fractionation, and hypofractionation, or single dose radiation, which you can go through in greater detail if you're interested. So let us now quickly gloss over the various modes of delivering the radiation. So radiation delivery can be grossly divided into external beam radiotherapy or teletherapy and brachytherapy. So very, very simply put, if the radiation beams are they fall on you from or they fall on the patient from a distance, it is called external beam radiotherapy, and brachytherapy is when radioactive sources are inserted into the tumor bearing area. So a classical example of brachytherapy is the intracavitary brachytherapy, where the radioactive source is placed within the vaginal vault, and this is generally done in cervical cancer. We can also have interstitial brachytherapy, where the source of radiation is embedded in the soft tissue of the tumor, and intraluminal brachytherapy, where the source is placed within the esophagus or trachea or rectum. So this is done for hollow structures. And there are various types of external beam radiotherapy, such as precision oriented radiotherapy and image guided radiotherapy, and conformal radiotherapy and intensity modulated radiotherapy. All of these use image guidance to more appropriately target the cancer cells while minimizing the damage to the surrounding cells. And something that we hear a lot, like cyber knife and gamma knife, is actually a form of radiotherapy, a very, very precise form of radiotherapy called stereotactic irradiation, where we use a 3D coordinate system to exactly localize the radioactive waves or the radiation onto the tumor cells so precisely that it's almost as if we were cutting it out with a knife. So these are various modes of radiation delivery that you must be familiar with. So one other very, very important tool in our armamentarium against cancer is chemotherapy. So chemotherapy consists of various drugs which have various mechanisms of action whereby they kill cancer cells, and also some targeted therapies where all those biological hallmarks of cancer that we were looking at earlier. So various hallmarks are targeted and cancer cells are killed. We have drugs that interfere with mitosis, such as vinca alkaloids and taxanes, such as paclitaxel and docetaxel. We have drugs that interfere with DNA synthesis, and these are generally called antimetabolites, such as 5-fluorouracil, methotrexate, mercaptopurine, gemcitabine, and capacitabine. There are also drugs that directly cause DNA damage, such as mitomycin C, cisplatin, carboplatin, oxaliplatin, and cyclophosphamide. And like we were saying, there are targeted therapies such as tyrosine kinase inhibitors, such as imatinib. So imatinib is a drug that revolutionized our treatment of some leukemias and also solid tumors such as chronic myeloid leukemia and solid tumors such as gastrointestinal stromal tumors. Also, we have immunotherapy agents such as ipilimumab. These are monoclonal antibodies that target specific areas of the cancer cell causing tumor lysis. And we also have VEGF inhibitors, that is vascular endothelial growth factor inhibitors, which target cells with increased angiogenesis. As we were discussing, angiogenesis is one of the hallmarks of cancer cells. So we have VEGF inhibitors such as bevacizumab, which are increasingly used in metastatic colon cancer. And finally, in cancer, as we know, more often than not, it is like we are fighting a losing battle, and sometimes a cure cannot be a target. Cure can no longer be achieved. In those cases, we have to focus on palliation or end of life care. And here, our approach focuses on pain relief, on making the patient comfortable, on managing the most troublesome symptoms, and on delaying the progression and improving the longevity if possible, and almost always trying our best to improve the quality of life of the patient. Because in cancer, as with any other disease, we are not treating merely the disease, but the patient as an individual. And this is something that we must never forget. With this, I am hoping that you understood, a few very, very key concepts in the principles of oncology, which will, help us to understand the disease better, and also, do our bit in treating the patients with this disease. Thank you.